So now we have Dr. Adit. I think Adit is one of the most prolific oculoplasty surgeon in India. He had done his fellowship, first fellowship from LV Prasad Eye Institute, Hyderabad, and then he went to US for his second fellowship under Dr. Robert Goldberg from UCLA. And Adit is the director of the Mumbai Eye Plastic Surgeries, that is their center. He's a great aesthetic surgeon and also does very good work in thyroid eye disease. Over to you, Adit.
Thank you, Dr. Kasturi, for this introduction. I also have to thank Debraj for running this course successfully for so many years. And it has always been well received. Today, unfortunately, we are post-gala night and everyone was dancing till 3 a.m. So obviously, it's an expected thing that you will have less attendance. But in this course, we usually run from the basics to advanced. So in the end, Debraj will be showing a cocktail of everything. And we will be going step by step, as Shilpa has already made my job easy by describing the anatomy. Now I'll go and touch the very basics of Botox, especially focusing more on the periocular region. We all know that Botox can be used for cosmetic as well as functional regions, and as ophthalmologists, we should be proud of the fact that the inventor of Botox was an ophthalmologist dermatologist couple who actually injected a person for glabular lines and for blepharospasm and noticed an improvement in the glabular lines, and that's how it got thrown into the cosmetic world. Now, before injecting, we all inject, right? We are all surgeons, so we know how to inject. More than injecting, I believe that for any injectable fillers, be it Botox, it's how you evaluate the patient and how you counsel them and how you know how not to say yes to a patient who is very manipulative or is going to be a problem patient. Before evaluating a patient, you should always know that skin is made of multiple layers, the face is made of multiple layers, and what we are targeting with Botox is just the dynamic lines. So you should not overpromise a patient that Botox is going to work magic. You should know that there are other structures which have to be addressed as well, which Debraj will be discussing in his talk. A lot of ophthalmologists who initiate their practice into Botox always tell me that, I'm not able to convince patients to get Botox done by me. While performing these aesthetic procedures, you have to choose your words with caution. You have to avoid certain words and have to be soft, like how you counsel a LASIK patient for this procedure. Photographic as well as videographic documentation is very, very important because, every patient has a different sort of sign map and you need to customize your treatment for every patient. So before injecting, you need to ask the patient to do all sorts of dynamic movements and see which muscle is more acting than the other and the pattern of the muscles and what kind of injection dosage would be required, which should be customized to each patient. Comfort of the patient is also again very important. So I always advocate to use skin anesthetic cream, which is a mixture of prilocaine and lidocaine. It should be applied copiously on the region that you are going to inject. It should be kept for a minimum duration of around 30 to 45 minutes because it numbs the skin to an extent that the prick can sometimes not be perceived at all. So here you can see we are applying in the eyebrow region the EMLA cream which is available. You can also use an occluder tape if you are in a hurry or the patient is in a hurry, because this occluder tape potentiates the action and penetration of the skin. It is available with the ointment itself. So instead of waiting for 45 minutes, you can perform your procedure maybe in half the time. This occluder tape certainly makes a big difference. Now, muscles have already been described by Shilpa, but what we focus on in the periocular region for Botox is mainly the orbicularis, the frontalis, and the eyebrow depressors muscles, which comprise of the corrugator, the depressor, and the procerus. Now, in the market, there are multiple options available. This is the APAO, so there are multiple options available in the Southeast Asian region as well. And once the patent of Botox was worn out 20 years after Allergan had to let go of the patent, there are multiple Botox molecules available in the Indian market as well, which are slightly cheaper than the original molecule and have fairly comparable efficacy. If you use it in your practice, you will come to know more about it. There are broad consensus guidelines which have been given by the PRS in 2004. This was one of the landmark articles where a broad consensus group had given guidelines, and now we have similar guidelines from the Indian group as well. But as a rule, usually you should use non-preservative normal saline because the pain of the injection is less. Concentration can be titrated according to your usage, and the label says that you should use the Botox for not more than 24 hours after reconstitution, but safely it has been shown that you can use it up to a month if stored properly, and special precautions should be followed while handling. It should be completely aseptic. Now, this is the biggest point that I emphasize on is keeping a track record, especially for the first 2, 3 injections. When you inject a patient, you need to know how a patient responds to the injection. So these charts are very easily available by the company wherever you procure your Botox from. These help a lot in your practice in the initial days to titrate the dose, to convince the patient that you are keeping their important records with them and show them that we've injected like this and do you want to change something about it. Consent again is very important from the medico legal point of view. Now let's come to specific indications. As ophthalmologists, we are very comfortable around the periocular area, but if one indication that you want to begin with initially is the crow's feet, because it's one of the safest sort of areas to inject. Very few things can go wrong in this area. For the crow's feet area, usually we begin with 3 points, the topmost, the middle and the lowermost, which is basically where the rytides are. The muscle that you're targeting in this area is the orbicularis oculi, which is a sphincter shaped muscle, goes around the eye. And depending on how radiating the crow's feet are, you might have to add more points beyond the 3 points that I spoke about. Now you have to administer caution while giving Botox in this area. You should not go too beneath, otherwise you will end up injecting the zygomaticus major and the minor muscles and cause a crooked smile. So you should be careful about that. And in the inferior crow's feet, you should not go too close to the orbicularis muscle because sometimes you might end with epiphora. While injecting the crow's feet, also one thing that you can do is you can keep your finger within the orbital rim to help the molecule from not diffusing in the orbit. The usual starting dose for crow's feet is around 12 to 30 units, depending whether it's a male or a female patient, and 2 to 5 injection points can be followed. This is a short video which shows how crow's feet injection is done in a patient. So this is the topmost point. Now, if you are comfortable, you can inject with the needle pointing towards the globe, but as beginners, I would advise that you can inject from the opposite direction where the needle is pointing away from the globe, and you can keep a finger within the orbital rim. Now this is the midpoint which was injected. Now since this patient had more radiating lines and wanted a elevation of the eyebrow as well, additional point is injected in the tail of the eyebrow, and then you see inferiorly just the lower crow's feet is targeted here. Patient usually tolerates these injections very well, and you just have to be subdermal, raise a bleb which just disappears in 4 to 5 hours, and then be careful that you don't go within the orbital rim. But not all crow's feet can be treated with Botox, so you should know this. As beginners, we are very excited to sort of go ahead and do Botox injections for all crow's feet, but sometimes it could be because of collagen degeneration, dermal sort of degradation, which causes static crow's feet as well, and these patients usually require filler injections or sometimes even a brow lift surgery. So this is something that you should be very careful about early initially in your practice. Now the second most common and safe area to inject is the forehead. Now forehead, basically you know that it basically comprises of the frontalis muscle, which can have variable anatomy. So there could be a bifid frontalis, there could be a monofid frontalis, which you need to know about. In the forehead area, although it's the easiest injection area, you know, you can have an interplay of the orbicularis and the frontalis muscle. So you should be very careful not to inadvertently inject in the orbicularis muscle, because then you will end up with a depressed eyebrow. So you should be at least 1 centimeter above the rim. You should also treat the lateral frontalis muscle, otherwise you will end up with a Spock phenomena. And you should avoid too much, you should not inject too much Botox, especially in the first sitting, because you will have frozen eyebrows and no movement at all, which looks very artificial. Now, as you see in this patient, this frontalis is a continuous frontalis, but sometimes there could be a pattern change where you could have two different frontalis muscles with a separate belly. Now, in this patient, we have injected these points. In males, you need to inject more as compared to the females. In females, the usual starting dose is around 10 to 15 units. In males, it is double. Sometimes you might have to add it up with a filler injection to hydrate the skin as well, because not all forehead lines, again, as I said, will just disappear with Botox. In females, the patterns, depending on the frontalis anatomy, will be different and can be sort of customized according to the patients. So as I said, in women, the usual starting dose would be around 10 to 15 units. In men, it would be around 20 to 30 units, because the muscle is bulkier than females. And then there is a technique called as microdroplet or watercolor Botox, where you dilute it 1:10. So if you're injecting 1 unit in 0.1, you inject 0.1 unit in 0.1 cc, which sort of gives a paintbrush effect on the whole forehead region and avoids a frozen look on the forehead region. Now coming to the last but the most important and the most dynamic structure on the face in the periocular region is the eyebrow. This is one of the most difficult areas to inject. Even expert injectors sometimes need 1 or 2 sessions to balance the eyebrow in a patient, especially for the first time, because this is an interplay of muscles. You're playing around with the orbicularis, the procerus, the corrugators, and the depressors. So in this, you have to first examine the range of movement of the eyebrow. Look for eyebrow tattoos and microblading eyebrows, because they have sometimes falsely elevated eyebrows. It's not the normal position of the eyebrows, so the muscles can get a little mixed up. Avoid too low injections, because you don't want to end up with a ptosis, because it's not reversible. It takes 3 months to go away on its own. And always ask for a history of prior surgeries, because that also can change the anatomy, because brow lifts tend to sever the corrugator muscles as well. Usual injection points are in the lateral eyebrow, the lateral 3 points where you want an arched eyebrow. In the medial eyebrow, usually you target the procerus and the corrugator muscles to elevate the medial eyebrow. And depending on how strong the corrugator is, you might inject 1 or 2 points depending on where the tail extends, but try not to go lateral to the mid-pupillary line, otherwise you might end up with a Spock phenomenon. These are usual standard points and the dosages followed as a convention in a patient if you're doing it for the first time. 4 units each in the belly of the corrugators, 4 units in the procerus, and around 2 to 3 units in the tail of the corrugator to get a nice subtle elevation of the eyebrows as seen here. Now this is a video showing how the eyebrows are injected. Now in the same patient, what we have done is we have so this is where the belly of the corrugator is injected. First, you have to inject you can either choose to inject the corrugator or the procerus. So look how I am injecting. Usually you keep a thumb beneath the orbital rim, because when you keep a thumb beneath the orbital rim, the chances of diffusion in the LPS are less. Ask the patient to frown and see till where the tail of the corrugator extends. So again, I'm keeping a thumb beneath the orbital rim as a safeguard. The other finger can be used to tap to distract the pain from the injection. This is called as tapping or tactile anesthesia. And then last could be the procerus, where you pinch the procerus muscle in the center and then inject. Sometimes the depressor supercilii might also be hyperactive and would have to be targeted. But what especially women like is an arched eyebrow, and in this you have to target the tail of the eyebrow. In these patients, sometimes you have to go within the eyebrow hair to inject, so that you can get a subtle relaxation of the lateral part of the orbicularis, and the topmost crow's feet or the tail of the eyebrow can be used to get a subtle elevation, especially laterally in women. So in the eyebrow, it's very important, especially if you're targeting a female patient, to inject in the lateral eyebrow. Males will not like this, because males do not like arched eyebrows. Usually the eyebrows are straighter in males. After injecting the eyebrows, you also have to, before going there, usually a starting dose of around 20 units for women and 30 to 35 units in men is a good starting point for the eyebrow region. Now, sometimes, as I said, even in this region, you might have exaggerated glabular lines, which have to be dealt in a stepwise manner, where you can soften these lines by doing Botox and then inject a little bit of filler in this region to sort of hydrate the skin and get a good result. So you might not get a desired result just by injecting Botox, but in this region, you have to be careful about injecting fillers, which Dr. Kasturi will be covering in her talk. Sometimes Botox can also be used to augment surgical results. In the Indian subcontinent, sometimes patients are very conservative and would not want to go ahead with a brow lift surgery because it is more extensive. So after doing a blepharoplasty, you can offer them a little bit of Botox to lift the eyebrow, especially the lateral part in these points, and you can get a subtle elevation of the eyebrow, which makes the patient happy in the first 3 months, which also sort of relieves you from any other questions, why did the surgery not give me the desired results. So I always do a little bit of Botox in upper blepharoplasty patients, in my patients, especially in my practice, and they're usually very happy. And if the patient is happy in the first 3 months after your surgery, they're usually going to be happy and not trouble you. You can also adjust the tarsal platform show. Now, these are advanced indications which you should do after acquiring a little bit of practice, where you can sort of symmetrize the eyelid fold by injecting in the orbicularis and also in the frontalis muscle and adjusting the position of the eyebrow. And we all know that usually Botox is known to cause ptosis, but you can also treat a little bit of ptosis up to an extent of 1 millimeter by injecting Botox in the eyelid itself. For this, you have to be very close to the eyelash margin, inject around the proprioceptors of the eyelid, and you can get around 0.75 to 1 millimeter of elevation by relaxing the pretarsal orbicularis. Last but not the least, always when you inject, especially for the first time in a patient, you should always call them for a follow-up at 2 weeks, because the first time when you inject, even in the hands of experienced injectors, you might end up with a Spock phenomena where you have not targeted the lateral orbicularis and the frontalis muscle, and you need to sort of titrate the patient, and this can be very easily dealt with by injecting just 1 or 2 units in the lateral frontalis muscle to relax the unopposed force of the frontalis, and you get a good result. In the end, the aim of Botox injection should not be to have a uniform expression all throughout. You should sort of retain the expressions of the patient so that you get a relaxed effect and a good outcome for the patient and not a frozen face. Thank you.